live by Dr. Pat, leading innovation in fertility excellence.
Imagine going through basically the most grueling physical and emotional marathon of your life.
Right, yeah.
You endure months of hormone injections, invasive retrievals, all these agonizing waits. And then finally, you get the news right. You have a perfectly healthy, genetically tested embryo, a euploid embryo.
The best possible scenario. Yeah.
Exactly. So you go in for the transfer. Everything looks fine on the monitors. The doctors are optimistic. And then it just fails to implant.
Mm-hmm.
And it happens again and again. And for decades, the medical explanation for this repeated implantation failure was, often just a sympathetic shrug.
Yeah, a lot of guessing.
Right. The assumption was either that the embryo had some completely undetectable flaw, or it was just this devastating case of bad luck.
It was incredibly frustrating for everyone involved, honestly. The focus was so intensely on the quality of the embryo itself.
Which makes sense. I mean, that's what you're transferring.
Exactly, but we were fundamentally neglecting the environment. We were assuming the soil was ready for the seed simply because we didn't have the appropriate flashlights, I guess you could say, to see that the maternal environment was actually biologically hostile to that embryo.
Okay, let's unpack this. Because today, we are doing a deep dive into two really massive sources of clinical data.
Yep.
We have a highly technical reference guide from Aspire and this incredibly comprehensive clinical text on volumetric sonographic assessment in reproductive medicine.
Yeah, it's a lot of material, but it's vital.
It is, and what these materials reveal is a complete paradigm shift.
Yeah.
We are moving away from traditional 2D ultrasounds and adopting advanced 3D transvaginal ultrasound, or 3D TVUS.
Right.
And it's completely transforming our understanding of the uterus.
Mm-hmm.
I mean, we are looking at a technology that is actively preventing unnecessary surgeries and, finally decoding those agonizing, unexplained IVF failures. Even if you aren't a medical professional, the sheer technological leap here is going to blow your mind.
To really grasp why this is such a monumental shift for you or, anyone navigating fertility treatments, we kind of have to look at the mechanical limitations of the standard 2D imaging.
The old reliable, right?
Right. The one that has been the universal first-line tool for decades. A 2D ultrasound transducer emits sound waves in this flat fan shape. It only captures what we call longitudinal or sagittal and transverse slices.
So it's essentially giving the clinician a cross-section of an apple. You see a flat slice, but you never actually see the whole apple at once.
That is exactly it.
Yeah.
And the human element here is that the clinician is then forced to mentally reconstruct a really complex three-dimensional organ in their head just from a series of moving two-dimensional slices.
Which sounds, frankly, exhausting.
It is. And human spatial reasoning is fallible. I mean, that mental modeling frequently fails to capture the true architectural complexity of the endometrial cavity, not to mention the thick muscle wall surrounding it.
Which is where 3D TVUS completely changes the game. According to our sources, this technology doesn't just take those flat slices. It captures a massive block of data using what are called voxels.
Right, voxels.
Yeah, and a voxel is basically a volumetric pixel, like a 3D pixel. The machine performs this automated mechanical sweep over the tissue, just hoovering up all these voxels in a few seconds.
It's incredibly fast.
Yeah. And then sophisticated software algorithms stitch all that volumetric data together to reconstruct what clinicians call the C-plane.
The C-plane, or the mid-coronal plane. It is basically the holy grail of uterine imaging. It's the entire rationale for deploying 3D technology in this field.
Because you're like trying to understand the layout of a house, right? Standard 2D ultrasound is like peering through a keyhole. You might see a sliver of the hallway, maybe a piece of a staircase, and you just have to guess the rest of the floor plan.
You're completely blind to the rest of the house.
Exactly. But the 3D C-plane, it takes the entire roof off a dollhouse. Suddenly, you are looking down from above. You see the complete floor plan, the layout of the inside rooms, and crucially, the exterior architectural shape of the house, all at the exact same time.
And seeing that inside cavity contour and the outside roof, what we technically call the external fundal serosa, seeing those simultaneously is absolutely mandatory for accurate diagnostics.
Because you can't get that on 2D.
You cannot reliably get that comprehensive view on a traditional 2D scan, no.
But I do have to push back on something in the sources that really caught me off guard, though.
Oh, what's that?
If MRI is the ultimate gold standard for soft tissue in almost every other medical show we watch, why does an ultrasound actually beat it here? Because the data is very clear. 3D TVUS outperforms MRI in this specific context?
Right. It's a great question. We're heavily conditioned to view MRI as the absolute peak of imaging technology.
Right, the big expensive machine.
Exactly. But the latest meta-analyses that are highlighted in our clinical texts show that 3D TVUS actually has higher specificity for certain anomalies and higher sensitivity for detecting internal structural walls.
But how?
The reason really comes down to real-time dynamics and focal resolution. The 3D ultrasound transducer is placed mere millimeters away from the target organ.
Oh, wow.
Yeah, so it provides an incredibly high-resolution mapping of the specific interface where the inner lining meets the muscle wall. It does this instantly, dynamically, and, without the exorbitant cost or the claustrophobia of being shoved into an MRI tube.
And remarkably, it even beats hysteroscopy, which sounds really counterintuitive because a hysteroscopy involves a surgeon physically putting a camera inside the uterus. You would think that direct visual would be the gold standard.
You would think so, but a camera inside the uterus only shows you the wallpaper of one specific room.
Oh, going back to the health analogy.
Exactly. You are completely blind to the structural thickness of the walls, and you have zero visibility of the external roof. 3D TVUS provides what we call a transmural assessment, meaning it lets the doctor see completely through the tissue, from the innermost cavity out to the external boundary.
And because clinicians can finally see that complete transmural picture, they started realizing just how many structural variations exist out there. They're hunting for congenital anomalies, which are often called Mullerian anomalies.
Yes.
These are structural variations in the shape of the uterus that a woman is actually born with. And how we diagnose these shapes turns out to be this huge battlefield of conflicting medical opinions.
The stakes in this diagnostic arena are incredibly high. The primary objective is differentiating a septate uterus from a bicornuate or an arcuate uterus.
So a septate uterus means there is a septum, right? A fibrous internal wall of tissue running straight down the middle of the uterine cavity, essentially dividing the room in half.
Yes, exactly.
And the sources note that this specific anomaly is profoundly associated with catastrophic reproductive outcomes, specifically recurrent early pregnancy loss.
It's a very serious condition.
So if a patient is diagnosed with a septate uterus, the standard treatment is surgical. A doctor goes in hysteroscopically to cut that wall and open up the space. But if a patient has a bicornuate uterus, which naturally has a sort of heart-shaped exterior, or an arcuate uterus, which just has a mild, normal dip at the top of the cavity, you leave it alone. The standard of care is conservative management. No surgery.
Because the physical intervention fundamentally differs based on the structural diagnosis.
Mm-hmm.
A misdiagnosis means either a woman undergoes an invasive surgery she didn't need, which risks scar tissue that could permanently damage her fertility, or she is denied a surgery that could have prevented her next miscarriage.
That is heavy.
It is. And historically, making this call was based on highly subjective clinical impressions from those limited 2D scans we talked about.
Which leads directly into this massive conflict detailed in the text. There are 3 competing medical rulebooks or classification systems used globally to diagnose these shapes. You've got ASRM, ESRE/ESGE, and SCUMI. And they all look at the exact same 3D ultrasound images, but they use entirely different math to define what legally constitutes a septum.
And this isn't just an obscure academic debate. I mean, it dictates patient care. The ESHRE criteria introduced this proportional metric. They established a rule stating that if the internal indentation, that dip at the top of the cavity, if that dip is greater than 50% of the overall uterine wall thickness, it is classified as a septum.
Wait, so depending on which rulebook your specific doctor happens to like, you might get put under the knife or you might get sent home.
Exactly, because wall thickness changes. When researchers applied that ESHRE 50% rule to a massive database of ultrasound images, a staggering 13.5% of the women were diagnosed with a septate uterus.
That's a huge number.
It is a massive jump from the ASRM criteria, which looked at the exact same women and diagnosed less than 2% of them.
That is wild. I mean, 13.5% versus 2% just based on the math.
Yeah, and the ESHRE system faced intense backlash in the medical community for this very reason. By relying on a proportional ratio, if a woman happens to naturally have a slightly thinner uterine wall, a completely normal, tiny anatomical dip suddenly exceeds that 50% threshold.
Oh, I see.
So the ESHRE criteria ends up reclassifying normal physiological variants as pathological conditions. It is a direct pathway to overtreatment.
That is a terrifying prospect for a patient. You seek help for fertility struggles, and just because of a mathematical ratio in one specific guidebook, you get put under the knife.
This raises an important question, though, about how consensus actually evolves. This is why the sources champion the CUME criteria as the optimal diagnostic standard.
CUME standing for the Congenital Uterine Malformation by Experts Group.
Right. They recognize the danger of these ratios and proposed a highly stringent, objective approach to really protect patients. Their rule is absolute. The internal indentation depth must measure 10 millimeters or more to be classified as a septum.
No percentages, no shifting goalposts based on wall thickness. Just a hard flat line at 10 millimeters.
Exactly. It creates a protective barrier against overdiagnosis, and it highlights a crucial point of empowerment for patients.
Yeah.
If a clinician suggests you have a septum and recommends surgical resection, the immediate follow-up question must be, well, which classification criteria are you using to make this diagnosis? We want to hear that they're using the 10 millimeter rule.
Absolutely. But the gross anatomical shape of the cavity is really only the first piece of the puzzle, right?
Yeah.
Once we know the room itself is structurally sound, we have to evaluate the integrity of the walls. And the texts focus heavily on this microscopic region called the junctional zone, or the JZ.
The junctional zone is arguably one of the most fascinating layers of human anatomy.
Really?
Oh, yeah. It is the highly specialized inner third of the myometrium, which is the muscle wall, situated directly beneath the endometrial lining. And its primary function isn't just structural, it is electrophysiological. It basically functions as the pacemaker of the uterus.
The pacemaker. So it generates physical contractions.
Yes, it creates these wave-like muscular contractions called uterine peristalsis. In the early part of a normal menstrual cycle, these microscopic waves ripple upward, helping to physically transport sperm toward the fallopian tubes.
Okay, that makes sense.
But during the critical window of implantation, when the embryo is actually trying to attach, this specific zone must enter a state of complete quiescence.
Like it has to freeze.
It has to become perfectly calm, like a completely still lake, so the embryo can anchor itself without being physically dislodged.
But for many women experiencing unexplained IVF failure, that lake is actually a stormy sea.
Unfortunately, yes.
The texts explore a condition called adenomyosis. This occurs when the endometrial tissue, the tissue that normally lines the inside of the cavity and sheds during a period, when that aggressively invades deep into that muscular junctional zone.
And that ectopic invasion provokes a highly pathological microenvironment. The invading tissue basically bleeds into the muscle every month, creating chronic inflammation, localized spikes in estrogen, and profound muscular dysrhythmia.
So the pacemaker essentially short circuits.
Exactly.
And clinicians use the MUSA criteria on 3D ultrasounds to spot this, right?
Yeah.
We're looking for direct signs, like literal fluid-filled cysts embedded deep in the muscle where they really shouldn't be.
Right.
And they also look for indirect signs, like a diffuse globular enlarged uterus that is visibly reacting to that structural weakening. But the most alarming metric is the thickness of the junctional zone itself. The sources state that if the JZ is thicker than 8 millimeters, or if that boundary line is totally obliterated by this invading tissue, it creates that muscular storm.
And if we connect this to the bigger picture, this is the biological aha moment for so many patients who have endured repeated failures.
Yeah.
You can have a perfectly graded, genetically normal embryo. You can execute a flawless physical transfer. But if the junctional zone is thickened, inflamed, and actively having microscopic spasms, the environment is just mechanically hostile.
The muscle wall physically contracts and expels the embryo before it ever even has a chance to burrow in.
Right. And traditional 2D ultrasounds frequently miss these subtle early signs of adenomyosis because they just couldn't map that coronal plane to see the jagged, irregular borders of the muscle layer.
So if a patient discovers their junctional zone is inflamed and contracting like this, what is the protocol? Is the environment permanently hostile?
No, and this is where 3D TVUS evolves from being a purely diagnostic camera into a therapeutic monitoring tool.
Oh, interesting.
Yeah. If adenomyosis is detected, the protocol often shifts to intense hormone suppression therapy. Clinicians use medications like GnRH agonists to put the patient into a temporary chemically induced menopause for several months prior to attempting an embryo transfer.
So the goal is to completely starve that invading ectopic tissue of estrogen, basically forcing the storm to calm down.
Exactly. It starves the tissue, minimizing the localized inflammation, and crucially silencing those hyperactive contractions. The clinician then uses serial 3D ultrasounds every few weeks to objectively track that progress.
So they can see it working.
Yeah. They can actually watch the total volume of the uterus shrink. They measure the junctional zone thinning out, dropping below that critical 8 mm threshold. They are meticulously timing the embryo transfer for the exact moment when the uterus has reached its absolute maximal state of muscular suppression.
Okay, so the shape of the rim is verified, and the muscular walls are finally calm and quiet.
Right.
The next phase of the deep dive focuses on the soil where the embryo actually lands and the plumbing network that feeds it.
The endometrium.
Exactly. We are looking at endometrial receptivity and blood flow. And our sources immediately dismantle a deeply entrenched medical myth regarding the thickness of the uterine lining.
This is a vital paradigm shift in reproductive medicine. For decades, measuring the linear thickness of the endometrial lining on a 2D scan was the primary fundamental metric for deciding if a patient was ready for transfer.
Right. Everyone always asks, how thick is my lining?
Exactly. But relying on structural thickness alone is a deeply flawed surrogate for actual functional receptivity.
Because the texts point out that exceptionally thick endometria can routinely fail to accept an embryo, while surprisingly thin ones can occasionally result in perfectly healthy pregnancies.
Yeah, sickness is really just a measurement of estrogen building up the tissue.
Right, but using VASCO, which stands for Virtual Organ Computer-Aided Analysis, it's a 3D software tool, researchers discovered that in a healthy receptive cycle, the total volume of the endometrium shouldn't just keep getting bigger and thicker.
No.
It should actually decrease after the body starts producing progesterone. It physically compacts.
And that volumetric reduction is a critical biological signal. When progesterone is introduced, either naturally or through medication, it basically extracts water from the tissue.
Oh, wow.
Yeah, this causes a profound structural compaction and dense secretory transformation within the cells themselves. They become denser, stickier, and far more capable of anchoring an embryo.
So what if it doesn't compact?
Well, if a patient undergoes a 3D volumetric scan, and their endometrial volume stays exactly the same after progesterone exposure, it highlights an underlying progesterone resistance at the cellular receptor level. The environment remains biologically hostile, regardless of how perfectly thick it looks on a standard 2D scan.
So the compaction proves the cells are actually listening to the hormones. But here's where it gets really interesting, because it gets even more granular. It's not just about the volume of the soil, it's about the blood flow reaching it.
Angiogenesis.
Crucial. The sources detail a technology called 3D power Doppler angiography, or 3D PDA. Now, standard color Doppler, which you might see in a normal hospital setting, measures the velocity or speed of blood. But 3D PDA is incredibly sensitive. It detects the actual amount of red blood cells moving through microscopic capillaries. And they use this to calculate the vascularization index.
Right, the vascularization index, or 6, calculates the absolute vessel density within the tissue because an embryo relies entirely on the mother's blood supply to survive.
Right, it doesn't have its own yet.
Exactly. If you don't have robust, unimpeded vascular perfusion creeping up to the surface of that lining, the trophoblast, which is the outermost cellular layer of the embryo, it cannot successfully invade the tissue to establish a placenta.
The sources actually break this blood flow down into 4 vascular zones. So think of the endometrium as a front lawn, and the blood vessels, the spiral arteries, as your underground sprinkler system.
I love this analogy.
Yeah, so Zone 1 and Zone 2 represent the outer edges of the yard deep down near the sidewalk. If your sprinkler system only has enough pressure to water Zones 1 and 2, the grass right in the center of the yard is going to dry up and die, no matter how deep or nutrient-rich the soil itself is.
Because the water never reaches it.
Exactly. And the texts state that if a patient's blood flow gets stuck in Zones 1 or 2, the clinical pregnancy rates are abysmal, hovering between just 8 to 10%, with a severely high risk of early miscarriage.
But Zone 3 indicates that those vital spiral arteries have successfully breached the inner layer of the endometrium. And Zone 4 means the vessels have fully extended all the way to the central cavity line, like the very middle of the lawn, right where the embryo is placed.
And the data here is just striking. If those spiral arteries successfully push into Zone 3 and Zone 4, the conception rates practically double, jumping to over 55%, with virtually zero vascular-related early miscarriage risk.
It's a game changer.
It is. So if a patient consistently only shows Zone 1 flow on a 3D ultrasound, constantly obsessing over the millimeter thickness of the lining is basically missing the forest for the trees.
It entirely misses the functional reality of the environment. The failure of those arteries to extend into Zone 3 signals severe microvascular hostility. Armed with this 3D data, a clinician can aggressively consider specific medications to enhance vasodilation and force that perfusion deeper into the tissue, rather than blindly wasting a precious embryo on a clinically dry environment.
Which brings up a massive logistical challenge, really. We've talked about the C-plane shape, the junctional zone thickness, the volume compaction, the zone 3 blood flow.
Yeah.
How does a human clinician possibly synthesize all of this disparate, highly complex data to make a confident, objective go or no-go decision on the actual morning of a transfer?
It's a lot of data, yeah. They rely on holistic multi-parametric scoring systems. The most robust and validated of these, heavily featured in the clinical text, is the Applebaum Uterine Biophysical Profile, or the UBP.
It is the ultimate report card for the uterus. It's a comprehensive 20-point master scoring system.
It grades 7 distinct ultrasound parameters to really just remove the guesswork. It does look at endometrial thickness, but it grades it on a bell curve where tissue that is far too thick is actually penalized.
Oh, that makes sense based on what we just learned.
Right, and it looks for a distinct 5-line layering pattern.
That 5-line pattern is fascinating. It's the visual representation of optimal estrogen exposure, right? Creating distinct, visible interfaces between the layers of the endometrium and the opposing walls of the cavity itself.
Exactly. Furthermore, the Applebaum profile actively counts myometrial contractions to ensure the muscle is completely quiet. And crucially, it heavily weights the presence of that zone 3 blood flow, dedicating a full 5 points to vascularity alone.
And the prognostic power of this 20-point system is absolute. The sources state that a score of 17 to 20 indicates an exceptionally favorable environment, correlating with near 100% clinical pregnancy rates in highly controlled euploid transfer populations.
Near 100%.
Yeah, but a score of 13 or lower.
Oh.
Multiple validation studies show a literal 0% conception rate. 0.
This scoring system serves as the ultimate clinical shield for the patient. I mean, we are talking about preventing the heartbreaking, physically exhausting, and financially draining loss of genetically normal embryos in a biologically hostile environment.
It's protective.
Highly protective. If a patient scores a 13, the clinician finally has the objective mathematical data required to cancel or postpone the cycle, alter the therapeutic approach, and simply wait for the profile to improve.
So what does this all mean for you? The primary takeaway from this deep dive is empowerment. If you or someone you love is facing the grueling journey of IVF, and especially if you face the trauma of repeated implantation failures, you do not have to settle for a basic 2D ultrasound that just measures the thickness of a line on a screen.
No, absolutely not.
You now have the vocabulary to advocate for a deeper look. You know to ask your clinic about 3D C-planes. You know to ask if they use the strict CUME criteria to prevent unnecessary structural surgeries. You know to ask about junctional zone suppression and whether your vascular blood flow reaches zone 3. Knowledge fundamentally changes the standard of care.
It really does.
3D TVUS is finally bringing visibility and engineer-level precision to the traditionally murky, guesswork-heavy waters of reproductive medicine.
It truly is illuminating the black box of implantation. And it leaves us with a really fascinating prospect for the future of this field.
Oh.
Well, we just outlined how incredibly complex the Applebaum 20-point scoring system is. It relies on clinicians using advanced software to manually trace voxels, measure fluid compaction algorithms, and literally count color Doppler pixels across microscopic vascular zones.
Right. It's so much manual calculation.
Exactly. Given the sheer overwhelming volume of spatial and hemodynamic data required to calculate these perfect clinical cutoffs, it raises a really compelling question. How soon until artificial intelligence completely takes over this 3D spatial analysis, entirely removing human bias, fatigue, and subjectivity from embryo transfer decisions?
Now, that is a thought to chew on. Until the AI takes over, though, ask for the 3D scan.
Leading innovation, fertility, excellence. Live by Dr. Pat. Leading innovation in fertility excellence.